Good afternoon, everyone. Oh my goodness. Well, here's a first. These are microphones that actually work at AEI. This has never happened in my entire career here. I can even hear myself being amplified. It must be horrifying for the rest of you. Well, I wanted to welcome you all to our very important event on long-term care today. Several of us are good examples of the people that you will have to support in your as we get older. And of course, the question in your uppermost in your mind is there a better way to pay for that? That's one of the topics we're going to be discussing. It turns out that in discussing financing long-term care, it's very difficult not to talk about, at least to some extent, where the services come from, who delivers them, and so on. It's a very complicated and difficult area, but it is an area that we as a country have to face. That baby boom generation, of which I think many of us on the panel are members, was a very, very big generation, some 70 million people or so. And unlike us, the rest of the baby boom generation is getting older. And in another, I don't know, maybe a few decades, many of the baby boomers will be looking at living situations where they will indeed need long-term care services and support. So this is a big issue financially, but it's a big issue socially, culturally, and in terms of family relationships as well. With that, let me just quickly introduce the panel. And one more thing about why we're having this meeting today. And it is because of the Long-Term Care Commission. The Long-Term Care Commission met last year under, shall we say, abbreviated circumstances. Bruce Chernoff will probably say something about that. And released the report in September. And Washington wasn't prepared to read it, I would say. And so it seemed like maybe early April, before taxes, after the ACA was, finished the open enrollment period, we thought maybe that would be the sweet spot to get people's attention. And indeed, it is a report and it is a topic that deserves our careful consideration. So with that, let me just quickly introduce people and then we'll get started. The first speaker will be Bruce Chernoff. Who is the president and CEO of the SCAN Foundation in California. But he was also the chairman of the Long-Term Care Commission. Then I'm going to introduce people in terms of speaking. So I hope I have this right. Judy Fader. Judy was a member of the commission, and she is a professor of public policy. At Georgetown University, and you're associated with the Urban Institute and many other fine institutions. Then the next speaker will be Ann Tumlinson. Ann is with Avalier, but before that, she was, among her many other jobs, she was with the Office of Management and Budget, trying to keep your costs down as taxpayers. Thank you, Ann. We appreciate that. Then the next speaker is John Bailey Jones. He is a professor of economics at the University of Albany, State University of New York, who's done a lot of interesting empirical research in this area. And then finally, Mark Warshawski, who is an adjunct scholar at AEI, and he was also not only a commissioner on the Long-Term Care Commission, but he was the deputy chairman. So we have two of the people who had the short straws, but actually there's someone else in the audience who had the shortest straw of all. Larry Atkins is here, and he was the executive director, which means that contrary to what you're going to hear from these people, he did all the work. Anyway, thank you very much, and Bruce, take it away.
Well, it's terrific to see all of you here today, Joe. Thank you for that wonderful introduction. I just want to begin by actually acknowledging Mark. Having Mark as my vice chair really made this work possible. I think if we demonstrate anything, the work that we were able to produce along with all of the commissioners, some of whom are here and up here, and I really want to acknowledge all of them, is that trying to solve the long-term care challenge that we face is not an intractable problem. And that this is the beginning of a really important discussion and one that needs to continue. So I, again, Joe, want to thank AEI for taking the time to sort of hear the report and then really talk about what the next steps can be and the challenges. I'm going to run through my slides really quickly because they're all there for you as a takeaway, so bear with me as we run through them. It's worth saying that at the very beginning, we had a very short time frame. So we were created as a New Year's Eve, New Year's Day surprise. We were supposed to have a 6-month window of time in which to act. We were supposed to focus on establishing, implementing, and financing a comprehensive long-term care system. Yes, please do all that in 6 months and report back. When you report back, we'd like you to report back not just with a comprehensive report, but we'd like it written in full legislative language. And then, oh yeah, by the way, it's going to take us about 90 days to find the funding for you. So the clock is going to run for 90 days, and you actually only have 90 days to do all that. The commission met over what was a very short period of time. We had 4 public meetings, 9 executive sessions. We took an amazing amount of public testimony, both in those meetings and through the website. And Mark and I set as a process to try to identify the places where there was broad agreement. So I would say that as the commissioners voted out their perspectives on the report, we were not asking commissioners to vote on whether they agreed with every single recommendation or not at the finest point of detail. But did this report actually represent a broad view of what next steps could look like? And what we ended up with was a 9-6 vote with a pretty equal mix of Democratic and Republican appointees voting in the affirmative. The commission report had a few very specific sections, and Larry Atkins really does get the credit and his team for helping us pull this off. We thought it was very important for there to be a clear call to action, which is the beginning of the report. We then lay out, with a little bit of data, the specific challenges to providing long-term services and supports, 3 areas of recommendations, which I'll touch on briefly, and then some comments about advancing the agenda. Finally, we used a process, Mark and I employed a process where we asked all the commissioners to put their best ideas on the table, and then we had all of the commissioners look at all of the ideas, sort of redacted from people's names, and pick a larger group than their own set of what they thought was most important. And then we went through a discussion, an iterative discussion process, and we thought it was very important that while a subset of those ideas made it into the final recommendations, that all the ideas should be on the table the way the commissioners wrote them, and so they're all in the appendix, because we think it's important that the breadth of opinions and ideas, even those that frankly didn't get all the way into the final report, were called out. There we go. With respect to the call to action, I'm just going to run through some of these things really quickly so we can get to financing. I think the commissioners as a group came away with this notion that there's 12 million folks who use services today. And honestly, if you look hard, those folks are all getting service somehow, some way. And many people feel pretty good about the services they're getting. Now that may be because they don't know what the alternative could be, and it may be that just having a steady state that works well is kind of a sense of relief, because any perturbation of that is a problem. But I think the commission as a whole saw that there was, that people are getting services, they're getting that care in the community, and that families play a really important role. That being said, it's not a singular population, and that there's very diverse needs, whether you're a child, whether you're a younger person with a disability, maybe working age, or whether you're an older person who has long-term care needs. In the call to action, then, we went to the place of kind of lining out what the problems are. Family caregivers provide an enormous amount of care, but it's very stressful, and their availability is going to decline over time. Long-term care is expensive and will only get more so. The direct care workforce is not as trained as well as we would like them to be, and they're a critical piece of the delivery system in the community. The system is very fragmented, and that's part of what leads to its inefficiencies. And finally, with the number of people growing in age who will need long-term services and supports, it's going to be really important that we think differently about where we're going as opposed to where we've been. So between now and 2050, the number of people who will need long-term care will more than double. That led the Commission then to lay out a vision for each of the three areas. We were all of good mind. We weren't imagining things. So this was meant to be a kind of a solid policy vision and not an imaginary exercise. We thought it was critical to lay out a framework for how to move forward. On the service delivery side, I think we really started with this notion it's about the person and the family, that there needs to be a balanced set of options and a real integration of medical and long-term services and supports in a way that is more efficacious and efficient. From a workforce perspective, we thought it was very important that we focus on how we attract and train the right workforce going forward, and then how to think about integrating them into person-centered care, and then what it means to have a team, how we do things like delegation. Finally, on financing, it was very interesting as while there are perspectives on how the Commission might have gone farther in the report, I think the Commission as a whole felt it was very important that there be a full array of long-term services and supports financing options, that there was real importance of a balance between public and private financing, that there needs to be a way to address catastrophic costs, and that individuals need to take responsibility for being prepared. And finally, coming back to that notion of what's the role of public programs, there will be a subset of people who need a robust safety net. So the challenge is to figure out what that safety net should look like going forward and who it serves. Quickly on the service delivery recommendations, because I think it is really important that you have to finance something. So having the financing discussion in the abstract sort of misses the point. In service delivery, rebalancing services was viewed as very important. Integrating care, so that all providers are talking with one another, that there is a single point of contact was viewed as incredibly important. Creating a uniform assessment that all providers and actually the family could work off of was an area of important recommendations. Better consumer access, new quality measures, and payment reforms that move us towards payment for site of service as opposed, service outcome as opposed to site of service. Those make up the big categories. Not a major focus today, but we can come back to them if there are questions. With respect to workforce, kind of three big areas. Family caregiving was a critical area. Families will continue to be, the backbone of support and care delivery and long-term care, and to think about what it really means to integrate them and support them was a place where there were multiple recommendations. We made recommendations about the paid workforce and the importance of revising scope of practice to encourage better delegation, and frankly that all providers should be scrutinized with the same kind of background checks, because frankly there's much less oversight in somebody's home than there is in the four walls of a hospital. And then finally, on the direct care workforce, we made recommendations about meaningful ladders and lattices for development and advancement, and ideas about better integrating direct care workers into care teams. With that, I want to talk a little bit about the financing component of the report. The one thing, again, that the Commission really did walk away with was a common vision. So this notion of a balance of public and private financing to ensure the most catastrophic expenses, encourage savings and insurance for more immediate long-term services and supports costs, and finally to provide a strong safety net for those without resources. What the Commission couldn't do in its very short period of time, and given the structure that we were using, which is where are the places of agreement as opposed to the places of disagreement, was to come up with a single financing recommendation. And so the Commission then laid out two differing approaches. It's interesting for me as the chair that they do overlap, because they have some commonalities, particularly around what's the role. Is there a role for a strong safety net? Is there a role for personal responsibility? And what is the problem in the middle to be solved? So the Commission presented two approaches. One that was more focused on private options to strengthen financing, and another that was based more on social insurance models. There were a handful of very specific financing recommendations, which I'm not going to cover here, but just call out to you around the current system, which is different than a big solve. And finally, the Commission raised the issue of next steps. And all of you being here today is part of that discussion. But the two that the Commission called out were, number one, that there's a need for this work to be followed up on, calling on Congress and the administration to think about what a next step could look like. Could it be, is there a branch of government or an active body that could pick up on these recommendations today? Some of them they all need more work, and some of them need, have more likelihood of moving forward than others. But is there a place in government today that could do this? Is there a need for a new body or structure? We didn't make a specific recommendation, but called out the need for Congress and the administration to think about that next step. And then finally, we thought it was very important for the White House to consider convening a 2015 conference on aging and disability, so that this is not just an issue for older people, but this is also an issue of functional needs for younger people as well. And they're not always included in these discussions. It's really important to call that out. So with respect to this recommendation, the Commission felt strongly that it would be more than just aging, but aging and disability. With that, I'm going to turn it over to Judy, and I'll be glad to take questions about the Commission's work later.
Thanks, Bruce. I'm going to go ahead and start while you're finding my slides. And I would just say that I was one of the commissioners who did not support the report. 5 of us issued an alternate report, and I hope you'll take a look at that too. And one of the issues that was most critical to us was to address the fundamental question that the commission was charged with, which is how should we pay for long-term care? And so I want to focus in just a few minutes. Joe's going to watch me like a hawk on the financing issue. So let me start by emphasizing that the need for expensive, extensive long-term care is a risk, not a certainty. And we understand that, I think, pretty easily for the roughly 40% of the population, as Bruce pointed out, who are under age 65. Sometimes it surprises people that so many of the long-term care people who need it are in that younger part of the population. Very small risk, 2% of them need it, but on a very big population. But what is less well understood is that even for people our age, Joe, the need for long-term care for a lot of it is a risk, not a certainty. So what I show you on this slide is that if you look at the bar on the left, 31% of people who are turning age 65 now are going to die without needing any long-term care. And then you have a lot of variation with 20% on the far right who are going to need care for more than 5 years. So you sometimes hear that almost everybody, 70% of the population, are going to need long-term care of the elderly population. That's the flip side of the 31%. But the amount they need is going to vary tremendously, and that was actually the point of the research that provided this data. Now, the variation in spending is even more dramatic, and we're focused on financing. So what you see in this slide is that 42% of people, older people who are likely to need long-term care, aren't going to incur any costs. Okay? But at the other end of the spectrum, you've got a very small percent of the population, 5%, who are going to incur, expected to incur more than $250,000 in spending, and that's in today's dollars. It would be much more than that, or not in today's dollars. It's a discounted present value, to be precise. It's what they need to put away today to have the money they need later. So a very small percent needing a lot of care and spending a lot of money. Now, what we need in order to deal with this kind of unpredictable, catastrophic risk is a mechanism to spread risk. Nobody, and I think that would go for members of this panel, would think that the right way to, the efficient and effective way to prepare is to save, because you're going to save too much or too little. And that's why we need an insurance mechanism, public or private. But the fact of the matter is that we don't have that. That's why we're addressing this question. Medicare doesn't cover long-term care. Private insurers are challenged in their ability to offer an affordable product that will really cover expenses when people need them, cover at the best of estimates, they would cover, I think we heard 1 in 5 Americans in the future under a lot of favorable assumptions. The flip side then is 80% without protection. Medicaid is our nation's long-term care safety net, but it only protects people after if they are poor, that's most of it, or if they've exhausted all their resources spending on health and long-term care. So that's kind of protection. It's not protection against financial catastrophe. It's protection only after you have a catastrophe. And then finally, the coverage, what you get under Medicaid, the access that people are looking for, particularly to care at home where they want to stay, is tremendously variable from place to place. So what we have is, and I would argue, inequitable, inadequate long-term care financing system. And if that isn't sufficiently bad news, it's only going to get worse as the population ages. The baby boom generation is coming, as we've heard, and the demands are going to grow. And while there's a big focus on projected spending for Medicaid that comes with that growth in demand, I, for one, am more worried that the services will not be forthcoming, and that instead that we will have a less equitable, less adequate service and financing system across the country. And as Joe started out addressing younger people, that's about all of us, because we're coming to live with you. So, you know, we really all need to care about this problem. So there were, the 5 of us in the alternate report recommended a strong role for social insurance, the various ways that could be done. But I wanted to offer up a proposal that I believe could generate considerable support as we go forward and offer us a way forward by truly creating an effective public base for all of us better preparing to ensure against this risk. What you can see, the bullets there, what I was proposing is that we establish a basic public benefit that's available to people when they experience need, that guarantees everybody a minimum level of protection. And that would be after a waiting period that would vary. It would be determined at retirement, and it would vary with people's lifetime earnings at retirement, so that people who have more money would get longer waiting periods that they'd have to fill in themselves, and people with less money would have shorter waiting periods. Details all TBD, to be determined. And we'd need a different formula to address the financing and the length of a waiting period for younger people who become disabled. What I believe about this approach, the reason I am advocating it, because it's an idea, we've got lots of other ideas, is that what it does is inform people about the hole they are likely to face in terms of their financing needs, and really establish an insurance mechanism that gives them time, for the older people, to prepare in some way, and that it simultaneously gives some certainty to the insurance industry about the hole that they could offer up to finance. More predictability, taking off, if you will, the risk tail that they find so challenging. So, something to think about going forward, and the bottom line here is that it is an uncertain, catastrophic risk. We need a mechanism to finance it, to spread that risk, and that public financing, some form of guaranteed public financing, needs to be at the core. Thanks.
Thank you, Judy. Ann, please.
Thank you. Joe, thank you for inviting me. It was fun working with you, getting ready for this event, and I'm just thrilled that AEI chose to do it. So thanks very much for holding this event. So the perspective that I'm going to share comes from a variety of experiences. I was not on the commission, but I'm friends with people on the commission. So I have a perspective that I hope will be grist for the mill for the conversation that we have after everyone makes their remarks. And my credibility for this perspective is the following. I did work at the Office of Management and Budget for many years, and my responsibility for the Medicaid budget Then after that, I worked for the last 14 years with assisted living facility providers and nursing home providers. So I certainly have an understanding of the population that they serve and how those people come to be in their buildings and how they pay for their care. I know a lot about how people pay for care in assisted living and nursing homes. And finally, probably the most rewarding part of my career for the last 14 years has actually been working with a variety of organizations, Department of Health and Human Services, the SCAN Foundation, among others, American Healthcare Association, in actually developing models where we were trying to figure out how could we, in fact, create an insurance program that would get a reasonable amount of participation so that it would be sustainable over the long term. And my organization, Avalair, built many models to try to estimate whether or not this was possible. So having done all of that, I've come to some conclusions here. And I would just start by saying, this is important, of what we can measure. And we can't measure very much, actually, about what we spend on long-term care. So of what we can measure, we spend about $200 billion a year on long-term care services and supports, but we pay for very little of the care that's actually provided. We depend on what some estimates would say about 65 million Americans to provide most of the care, and they do it without payment. Because most Americans are not protected against the financial risks, and they really want to avoid a Medicaid nursing home bed. So the long-term care system is woefully underfinanced for the job it has to do now and in the future. I'm going to make 3 points with respect to that I hope will generate some interesting discussion later. The first is that it's my view that the problem that we have to solve here today is not a Medicaid budget problem. Governors and state governments are going to face challenges as the population ages, no doubt. But in managing these challenges, even more of a financing gap is going to be created. Long-term care is actually shrinking as a percentage of Medicaid budgets right now. It's at the lowest percentage it's been at in 2 decades. Over the last 10 years, Medicaid long-term care spending has grown at an average annual rate of less than 5% a year. Why is that? Well, it's because governors and state governments and governors have a lot of control, in fact, over how much they spend. They don't have as much control as they would like, for sure, but they certainly do have control over certain things. And so they use these levers, they exercise these budget levers, essentially to reduce not necessarily the number of people who can qualify for Medicaid nursing home care, but to reduce the amount that they spend. And in fact, we see that reflected already in the growing interest among states in shifting from fee-for-service programs to managed care programs for providers. In other words, relative to the number of people who would need long-term care, there will be fewer Medicaid dollars to go around. So that brings me to my second point. The inability of Medicaid to keep up with the growing demand points to the real problem, which is the underfinancing of long-term care. It creates and contributes to enormous economic insecurity for the majority of American families. And when they're faced with a crisis, most Americans cobble together a variety of resources to provide what they can. Less than 2 million out of the 12 who need long-term care, roughly 12 who need long-term care, actually live in a nursing home. The rest live in the community where Medicaid dollars are very scarce, and where 1/3 of all American families report providing some type of caregiving. Again, this is the caregiving that is provided unpaid. The time that they spend doing this caregiving is really hard, really physically demanding and challenging work. And oftentimes they do it while holding down another job. Of those who are living in nursing homes on Medicaid, the situation is very grim. Even the most ardent nursing home opponents will concede that all but maybe one state are paying below cost, relying on the Medicare program, the other program that most elderly are enrolled in, to actually subsidize the costs where possible. Research shows that the more a nursing home relies on Medicaid for revenue, the more likely the facility will exhibit quality problems. So anyone with any resources at all is running like crazy to the burgeoning senior living industry. And we know from industry data that over 1 million people are paying privately right now for assisted living care or some type of senior housing that costs over about $42,000 per year on average. Families are stretching to make this work. This is not, while it is a service that's available to people who have resources, we know, though, that adult children pay for about 1/3 of the cost for assisted living, and that the residents and assisted living facility providers will tell you that their residents actually exhaust their resources while in these facilities. as opposed to in nursing homes. And this is really important because none of this is captured in our national data. You can't see this. You can't go to the national health spending accounts and see how much Americans are spending on assisted living, or how much family caregivers are providing unpaid, or how much private duty nursing is nursing in the home is contributing to all of this. In other words, families are really making heroic efforts in order to make this whole situation better for their loved ones. So after years of working directly with providers, analyzing the data, my conclusion is that Americans from all walks of life can be devastated by a long-term care need. That as a safety net, actually Medicaid works pretty well. But based on 20 years working with providers, my experience is that Medicaid is generally viewed as something to be avoided if at all possible. And the real point, and this is kind of my final point, the real point of policy now is how can we improve the financing by spreading risk? How can we create an insurance mechanism that will allow as many people as possible to participate and really shift the way that we pay for long-term care in this country from one in which we are essentially relying on the resources of families and Medicaid to do it? And so this is the controversial point that I will make. After building these models and talking to lots of really smart actuaries, I would say that I'm of the view now, anyway, for right now, and I could change this view, hopefully I'll get proven wrong, that in order to adequately protect Americans against the risk of long-term care need, some part of this risk must be shared by everyone. I look forward to the discussion.
Okay, well, get your wallets out, everybody. John?
The gray button. Okay, so I'm really grateful for the opportunity to get out of Albany and to actually I love Albany and to come down here and briefly talk about some of my work. There we go. Brilliant. Okay, so just a quick refresher on the distinction between Medicare and Medicaid. Pretty much every senior person is eligible for Medicare. It is not income or asset tested. There's really no means testing. But while it covers a lot of medical expenses, it doesn't cover everything, and especially some of the long-term care services that we're interested in today. For example, extended stays in nursing homes. So that moves us to Medicaid. This is means-tested health insurance for the poor or the impoverished. And that may sound like I'm repeating myself, but there is a distinction. So when I refer to the poor here, I'm talking about people that essentially have been poor their entire lives and enter retirement with very low income and wealth. When I'm talking about the impoverished, I'm talking about people that may have been reasonably affluent at the beginning of retirement, but their resources have proven inadequate to cover their medical needs. And so when it comes to long-term care, Medicaid does play a pretty big role. As the slide says, it pays for about 70% of the nights spent in nursing homes. And it turns out that 62% of Medicaid transfers for the elderly are for nursing home payments. So it is a big deal. So what I want to briefly talk about today is some of our research where we've sort of looked at the differential impacts of Medicaid across the income distribution. And naturally, Medicaid is typically considered a program for the poor, but, and Joe asked me to give you 3 points, I'll give you 4. The first point is that rich people tend to live longer than poor people, so they have more of an opportunity to rack up expensive medical expenditures. And also, as you age, the sort of diseases you pick up tend to change as well. Secondly, rich people do receive Medicaid, and I don't have the slides here today, but you can really see that when they become very old, especially when people start moving into their 90s, even people at the top of our income measures have a fairly high probability of getting I shouldn't say high, but have a non-trivial probability of getting Medicaid. Perhaps even more important, when these people do get Medicaid transfers, they're big. Okay, so If someone is reasonably affluent is getting Medicaid, it's because they have a catastrophic expense, and because it's a transfer that occurs when you have a catastrophic expense, they place a very high insurance value on it. So in some sense, in terms of the insurance that they place, the insurance value they place on Medicaid, it's actually the richest people that place the highest value. Maybe they don't get as much insurance, but they really value it a lot. Okay, I'm going to basically show you 2 or 3 slides. Briefly, where am I getting the data from? From two main data sets. One is the AHEAD data set, which is the data set of people 70 and older. And the other is the Medicare Current Beneficiary Survey. We have 10 to 15 years worth of data. The one thing that I think I want to be precise about is we talk about rich versus poor in this paper a bit. How do we define that? We have a measure of income, and this income is basically the pension benefits you receive upon retirement. So some of your Social Security benefits and your defined benefit pensions. And the idea is people that are getting big pensions probably earned a lot during their lives, and there's probably a good chance they've also accumulated a lot of wealth. But anyway, when you look at the tables, that's the measure of income we're using to sort people by. We're going to look just at singles for the moment. This really has to do with the models that we apply this data to. We'll get into the details of that. Okay, so the first point, I said that rich people live longer. Here are some calculations of life expectancy as of age 70. Perhaps if you look at the far right column, this is sort of overall averages by income percentile. And you can see that people at the 10th percentile live about an average of 10 years, and people at the 90th percentile live an average of 14 years. And moreover, if you looked at that distribution and sort of the odds of living to a very, very old age, it's much, much higher for the richer people. Okay. And finally, here's a little bit of data on who gets Medicaid. So first of all, we've got the recipiency rates. Not surprisingly, the most poor, about 70% of them, are getting Medicaid. Averaging across people that do and don't get Medicaid, the most poor get an average of about $6,000 a head. A few of these people don't get Medicaid. Once you throw them out, you're at about $9,000. Let's look at the very top. Only about 5% of these people actually end up getting Medicaid. And averaging across everybody, people who are getting it and people who aren't, you get about $900 a head. But what I'd like to stress is that the people that do get Medicaid are getting about $17,000 a head. So it's a pretty big pop. And this sort of gets back to my point that while the people at the higher portions of the income distribution might not be very likely to get Medicaid, when they get it, it's in a situation that from their view is pretty dire. It's coming in when they have lost a considerable amount of income and wealth and really typically face catastrophic medical expenses. And so sort of the punchline here is that while Medicaid may primarily be spending most of its bucks to the poor, it is not just a program for the poor.
Okay, John, thank you very much. I had a question that may be on everybody else's mind. So at what age in this survey is income measured?
So this is basically, these are people 70 and older. And so we see them for a number of years, and we just sort of average their self-reports of Social Security benefits and pension benefits over the years, just in case there's a little self-reporting.
I see. So basically, it's Social Security benefits, perhaps adjusted for the age of recipiency. No.
Right. It's basically what's the check they get in the mail every month? Yeah. Check or checks.
So that's the determination of higher income versus lower income.
Exactly.
Okay.
Right. So
right. I think we'll have a little discussion to that.
Right. But the point is, we think it does kind of map into what you might have earned over your entire life.
Right. Okay, thanks. And Mark, you're next.
Okay,
Let's see.
great.
Oh, perfect.
Again, thanks everyone for coming, and to Joe for helping to organize this. What I'm going to do in my presentation is first I'm going to present some relevant empirical facts and some findings from studies that I think some of them are a little overlooked, and I think they're very important in terms of establishing a base for doing policy. Then I'll discuss the policy implications that some of us from the Commission that I guess it's financing proposal A in the Commission report that we drew from these facts and put forward as a possibility in terms of financing mechanisms as part of the Long-Term Care Commissioner report. And in this regard, I want to acknowledge Grace Marie Turner, who's here, who is part of that group. So let me start, as I said, with some facts, some data. First, this is from a relatively new survey, and it shows the percent of the elderly needing assistance from others by age group. My point in showing this data is that the need for long-term care is definitely part of the aging process. It's very common, and it really does not come as a surprise, I think, to anybody that this is something that could happen and often does happen. And therefore, it can be planned for. Certainly, insurances can be part of that planning, but it's just looking at it in terms of the way it increases by age. It is part of the aging process. There are many sources of help for elderly community residents that are disabled. And here we look at it both by age and by the source of help. A spouse is significant, children are very significant, and also paid helpers. The need for the paid help increases with age, but the point is that the vast majority of care, which I think has already been mentioned, is provided by family members. And this is an important issue in terms of designing any public programs, or for that matter, even private insurance programs, that there is a concern of crowd out. And I think we need to be wide-eyed about that issue. In terms of the question of, is there currently unmet need for personal assistance among community residents? Here I'm just going to summarize one study which was done, and we had Professor Kay come into the Commission to talk about some of his research. The bottom line, and it's really the next to last bullet, is that unmet needs fall to 4.5% of total needed hours. So people are getting care. It is cobbled together, admittedly, but there aren't people who have no assistance who need care. That is very, very rare. The payment for long-term care, there's a little bit of a controversy in the field as to whether to include Medicare or not. I'm using Congressional Budget Office numbers, and they include Medicare. So the vast majority of payment for formal long-term care for the elderly is provided by the government through Medicare and Medicaid. Other includes mainly Defense Department and veterans programs. What is paid for out of pocket or by private insurance is a minority of the care that is financed currently. This is current data. Looking at projections, this also comes from the Congressional Budget Office. Spending on long-term care is projected to climb from 1.3% of GDP currently to 3% in 2050 at current prevalence rates, which I think is the reasonable assumption, as the CBO does. This is both in Medicare and Medicaid. And at the bottom line, the bottom point in this slide, I think, is the important one. Taken in a vacuum, this is a significant increase in spending, mainly because of the aging of the population. But when you put it in the broader context of what's going on with Social Security, Medicare, now the ACA, this is simply unsustainable. The public long-term care spending for the elderly is simply not sustainable. And really, I think what we need to find is more sources of private funding. The question is, could private long-term care insurance fill that bill? Now, there's a lot of data on this slide about the history of long-term care insurance. I think it's significant to note that it was a growing coverage and growing field just very recently from 1999 to 2005. There were a lot of companies in it, and the premiums were growing. The number of people that were covered were growing. And I mention this because this discussion about whether private long-term care insurance can work or not is a very old discussion. It goes back to this field. I think it was even discussed in the Pepper Commission. Even then. And some people said it will never work. There will never be private long-term care insurance. But the reality is that there was growth in that industry and in that coverage. But in 2005, the market, I think we need to be also wide-eyed here, that there were problems. Some of those problems relate to changes in the macroeconomic environment, particularly the rapid decline in interest rates, which basically threw the pricing into a tizzy. But some of it is the misjudgment of the industry, and in particular on the, sort of ironically, they assumed that people would lapse their policies, and they priced accordingly. Well, look what happened. People didn't lapse their policies. They really see value in long-term care insurance. Maybe it's some of those people that John talked about. Well, that also caused a problem for the profit of the industry, and I think that's something that we do need to deal with in terms of regulatory policy and new designs in long-term care insurance. We also heard on the commission from Jeff Brown, who with his co-author Amy Finkelstein, who are just the top of the profession that have worked in this area. They estimate that Medicaid can explain the lack of private insurance purchases for at least 2/3 and perhaps as much as 90% of the wealth distribution. So that that's why people don't, even though there was growth, it's still only 11% of the population that has long-term care insurance. So they claim that it's Medicaid crowd out. Now there is some empirical evidence for this. In another study they found that states with more generous Medicaid eligibility had lower rates of private long-term care insurance. Also, there are extensive surveys, and I think this is just common experience, that people are really confused about what Medicare, what Medicaid. They don't even know the difference between Medicare and Medicaid, and whether it covers long-term care. We hear this repeatedly, and the surveys certainly find that should be the case. Now, the question of Medicaid eligibility, we've talked a little bit about this. I think the second bullet is very important to emphasize. According to the rules, this isn't sort of illegal activity or very smart lawyering and gaming. These are the rules, either the simple, sort of complicated rules of Medicaid eligibility. You can be eligible for Medicaid and still exclude the following assets: your house, up to $814,000 in many states, your automobile, personal valuables, term life insurance, retirement assets in a distribution mode, which everyone after age 70.5 is in, and this is not necessarily a lifetime distribution, and $117,240 for a community spouse. If you have that, that's clearly more than $1 million. That is according to the rules that you're still eligible for Medicaid. And this wouldn't be as necessarily much of a problem or a budget problem if the states did what they were required to do, which was to recover from the estate of a decedent, Medicaid decedent, particularly the value of a home, but states don't do this. And it's a long discussion as to why that might be so, but the reality is, according to the latest study, very few do much in the way of estate recovery. So, with those as the facts, let's discuss private market solutions. And what we have, I think, 5 slides on this. The first set of slides is to tighten Medicaid eligibility rules. I'm still not quite understanding why this would be controversial, why we would want rich people to be eligible for Medicaid, why we want the government to pay for people who have significant assets or could have devoted planning and resources to this. Why we would want that is a mystery to me, particularly because it does crowd out the ability to plan and to prepare for this. So this slide has many aspects of doing that, but those are more technical issues. But the technical issues are really important because that determines who's eligible. In terms of sort of jump-starting, again, the private long-term care insurance market, our group also proposed, but this is an old proposal, tax incentives for long-term care. We did this maybe in a little bit different way in terms of allowing withdrawals without triggering a taxable distribution event from retirement assets or from a Section 125 account. Like any tax advantage, tax incentive, like with health insurance for that matter, this is more beneficial to the upper income just because of the progressivity of the income tax. But as we've seen, they do use Medicaid services and rely on Medicaid, so there is a saving from the government if they're covered by private insurance. In terms of new types of insurance, I'm going to be a little immodest. This is an idea which I have proposed over the years, something called the life care annuity. One of the problems, another issue in long-term care insurance is, particularly if it's purchased at retirement ages, is that you do have to go through underwriting, and if you're in poor health or even modestly poor health, or have some lifestyle issues, either you will get insurance at a very restricted coverage or at a very high premium, or you won't be able to get it at all. And that actually does represent a significant part of the population. As many as 25 to 30% of the elderly population would not be able to get long-term care insurance. And that is a significant public policy issue, and it's, I think, a marketing issue, frankly. And so what I came up with is a combination of long-term care insurance with a life annuity. So you basically are dealing with risks that do face all elderly. And the advantage, and again, I won't have time to go through the details, is by pooling different segments of the elderly population, you can offer this combination policy with very little underwriting. So people who currently cannot get long-term care insurance would be able to get coverage through the life care annuity, and it would be slightly cheaper. And then in terms of directly dealing with the issue that Brown and Finkelstein identified of crowd out, the one we think the most direct way and head-on, and maybe a little bit, the other ideas that I've been talking about are a little more incremental. This one is a little more forward-leaning, is to allow for a Medicaid carve-out, whereby upon retirement, individuals could choose to get a lump sum payment from the government for a significant portion of their expected value of their Medicaid benefits. So this would be more for the poor, little or nothing for the better off, and they would use this to buy permanent long-term care insurance. This would, because it wouldn't be a dollar for dollar for Medicaid, there would be a saving to the government, but the important thing is it would allow the private sector to experiment with different policy types and meet people's needs in terms of what they want. Do they want more home care coverage, et cetera, and this would be, instead of through a government mechanism, this would be through the private sector, would meet people's needs, I think, most efficiently and most effectively. And then finally, in terms of the regulatory environment for private long-term care insurance, this is largely a state issue because insurance is regulated at the state level. There are some federal issues as well because of tax issues. So we have three ideas here. One is that we would like to loosen up state regulations to allow high deductible long-term care insurance, whereby just catastrophic coverage would be covered. And this would provide clarity in terms of if people don't want to spend that much money on insurance, they wouldn't have to. They could save for the gap, but they would have the coverage for catastrophic. This is currently actually not allowed under current regulations. And we propose that be fixed. We also think there needs to be a little more flexibility in terms of the design of the policies to reflect changes in the macroeconomic environment in both directions. So in other words, where the prices need to go up, they need to go up, but when prices can go down, they need to come down as well in reflection of changes in macroeconomics. So those are our proposals, and I think we now look forward to a good discussion.
Okay, thanks. Thanks very much. I appreciate everybody speaking quickly. It's a pretty big panel, and now we will have some even faster talking. Possibly. We're going to start off by me asking some questions and just kind of throwing it open to the panel and see what happens, and then we'll get to the audience. We're scheduled to go until 2 o'clock, so I think there'll be plenty of time for people to interrogate the panel. It strikes me, Judy, that your presentation makes a good argument that we're talking about an insurable, well, I'm going to say event, even though it's actually a series of events, but to simplify it, an insurable set of events. And your argument is that that the private sector needs some help from the government in order to be able to sell the product, in essence, to take some of the risk away. I think Mark's proposal is that at least his favorite form of long-term care insurance, which includes a life annuity, the theory of it is that you have offsetting risks, in essence, that somebody is likely to use, likely to live longer, might have many more years of paying in before they need long-term care coverage, if at all. I think that's basically it, right? But the commission, and I think you supported this, Mark, also supported the idea of giving a new kind of a tax break for long-term care insurance that doesn't previously exist. So you're really, it seems to me, coming from the same fiscal place, which is we need more taxpayer-financed financing, one way or the other. I think there are different mechanisms. In this era of tight budgets, and thinking also that we just had a big health reform that will greatly expand federal spending on that other part of healthcare. Isn't there some way that we could rearrange our priorities and balance things out a little bit better so that, first of all, it isn't all just healthcare, medical care. It's not just medical care, but it's also not just healthcare. We have a lot of other public sector priorities that we want to do. So do you really think? Do either of you really think that it's practical to propose what is essentially, either through taxes or through a program, a new federal entitlement?
All right. Well, I think the point of our proposal was to encourage much more significant forthcoming for private resources, either through insurance or through saving. But I think we do acknowledge that there needs to be some structure to this system and some encouragement. So I think on net, I know we didn't get a CBO estimate, so this is speculation on my part, certainly. But I think on net, all of these proposals, if you sort of include them, they would represent a savings to the government. In particular, if you think about it in terms of long-term projections, and when you consider that there's such significant use currently of the fiscal of government spending for this long-term care need.
So I would first of all clarify that my objective, although I do believe that what I propose would enhance the potential for an effective long-term care private industry, my objective is to actually get people meaningful protection against a serious risk and to get them affordable access to care. And I do believe that requires a public investment, and I believe that a good public policy discussion, which we unfortunately have too few of, needs to address what's really needed rather than to start by addressing political constraints, because you don't get where you want to go unless you establish the groundwork. and I think it'll take some time. The problem that I have, many issues with what Mark put forward, but apropos where we put limited resources, and I'm glad you pointed out, Joe, that tax breaks are spending, and I don't agree that these measures would not score. The tax breaks, as you acknowledged, Mark, are going to go to the better off. And if we're going to invest, a priority investment, I think, has to be to those who are more challenged economically and socially, and not to the better off. So, as I argued, and I'm happy to provide more evidence of, the limits to Medicaid coverage today varies tremendously, and is only going to get worse. So, if we do nothing else, then the first dollars need to go to secure the safety net, which is, I think, what Ann was emphasizing as well. And the reality that we do need more resources is that we do need more resources in this system. And I think that if we address it properly and describe what it is that's needed, and have what's considered a reasonable solution or a reasonable approach in which all of us are contributing, as Ann said something, that's the way you build political support for measures, and that to really address the problem is what you need to do. You need to build that support.
I definitely need to say something here, because having worked at OMB, where my job really I viewed at the time, my job was to, in fact, try to contain government spending as much as possible and try to find ways in which to make programs as efficient as possible. And so that's very much always been my mindset. It is somewhat horrifying to find myself in the position of actually suggesting that we need a new program. But I've been working on this a very long time, and I've looked at a lot of different ideas, and I've even been a proponent of different ideas. And I cannot come up, it is my view now that is not sustainable or workable for us to not do anything. And it is not possible to solve the problem that we have to solve unless we do, in fact, inject the government into this in some way and create a mechanism through which everyone can spread risk. What we've learned from the actuaries in the process of doing all of this modeling is that it is almost impossible to protect one person without protecting all people, and mathematically, actually, very challenging to do. So that I think we're not really in a place where we have a choice, and we have to figure out which idea is in fact going to work best from a slightly logistical perspective. But that's kind of where we are.
Would add one more word. I know, Joe, when after we talked, you said, so get out your wallets. And I think the point is that the wallets come out regardless. The question is whether the burden out of that wallet is coming all from the affected family's resources, or we have found some way to spread the risk.
Well, we could continue, but I think a question of a mandate, which is really what we have on the table, is I think an interesting point. It's politically very unpopular. I think we've seen that with the ACA, and I think the reality of whether there is a mandate or not a mandate, I think, is also up for again, practical discussion in terms of, although in the law there seems to be a mandate, in reality there doesn't seem to be a mandate. And I think when you would translate that, which is in health insurance, which I think people have a sense of, even a better sense of, I need this right now, or I'm exposed to health insurance risk. When you talk about long-term care, I think part of the problem that we face is that people, although it's a risk that everyone should know or does know in some subconscious way, it's a very difficult issue. And to think that we're going to mandate coverage for that, I think is not practical, so I think we need to provide incentives. I think
Yeah.
that's the way to go.
And you're making a good point that I don't think I heard from anybody earlier, which is the big difference between, or a big difference between health insurance, traditional health insurance, and some sort of a mechanism that you buy for yourself, either long-term care insurance or savings for long-term care. And that is, with health insurance, there is the expectation that you will use it immediately. In fact, there's the near certainty, because of course it's not truly insurance, it's mostly prepayment for all sorts of things, right? So the reason why health insurance sells so well, in addition to the subsidy that a lot of people get, but I think the real issue is that people somehow can see this is a more immediate satisfaction of some need that they're very likely to have. Whereas with long-term care, I don't think I heard anybody say this, but I think it's something that nobody wants to think about. It's called aging, and it's especially the part of aging that I think scare people the most. And it's essentially investing your money into something that you'd rather not have happen. So it's a really difficult product to sell. And so I think Mark's idea about combining annuities with, I mean, in addition to the risk, offsetting risk factor, it's also, there's a sense that you get something out of this.
No, Joe, I'm interested, you mentioned that and emphasized it initially in Mark's proposal. It's one that Mark has been advocating and thinking about for a very long time, and seems to analysts to be a very attractive insurance product, private insurance product. But that product, even with that product, were Mark able to sell it, which he unfortunately has not been able to. So the industry's not biting at what sounds very attractive. Even if you were able to buy it, the numbers of people likely to buy it remain quite small. So I think that while you are absolutely, I think, right to focus on ways to make products better, to think of that in and of itself as addressing the financing problem and the enormity of it, you're kidding yourself.
Yeah, can I just one more thing, because I think it's important to be clear when I talk about sharing risk across a broad population, and the problem that solves is, let me say this a little differently. There's a lot of good that we can do with some of the ideas that Mark has put forward. I mean, there's a lot of good that can come from improving the private long-term care insurance market. People who buy those policies will, in fact, have access to better products as a result. I think there's, I've said actually for many years, I've been a big proponent of creating some type of a Medigap selection panel for long-term care insurance, so that we can give people easier ways to make selections and all kinds of things like that. That's all fine. And if we do that, it won't be bad necessarily, but it won't address the enormity of the problem, as Judy says. It won't, the modeling that we have done shows that doesn't, in fact, really change how our financing system is fundamentally structured. So I wouldn't want to come across as though I oppose those ideas, because I don't oppose them per se. I just, my analysis has shown that it doesn't, in fact, really change the way that our system is set up. It might make it a little bit better, but it's not going to, Medicaid will still be the primary payer.
And so that brings up the other question, and then we'll go to the audience, which is, what about crowd out? I think there are vastly different views about this, and I thought this would give John a chance to say a little something more about the analysis that he's done and that others have done, and then Judy will, of course, refute him.
Well, I mean, the work I showed earlier suggests that, that Medicaid provides some pretty significant and valuable services. I don't know that work has much to add over what Brown and Finkelstein have done earlier. I will mention somebody else's paper, very interesting study by a couple of economists, where they have looked around Europe, basically, or the OECD, and what they basically find is that countries that have a broader government-provided long-term care safety net are characterized by lower rates of saving by the elderly. And that suggests that there is probably some sort of crowd on it. I think, I think we can argue about the magnitudes, but I guess my gut sense is that it does exist.
Can I actually just ask a quick question? Sorry to geek out on everybody here for a second, but were you able to see whether or not the folks who were in that category of the rich who did access Medicaid, whether HRS has a variable for private long-term care insurance on it? Could you see of those people how many of them have impact private? Because a lot of times people do buy private long-term care insurance and then they blow through that plus their savings.
That's a good question. I don't know that we have. I'll have to look into that.
It'd be cool to look at it if you would.
Way cool.
Yeah.
So if I remember correctly, John, the rich, the top quintile in your study of single women had incomes of $40,000, that was the cutoff. So they were the higher segment of that population. But as I suggested to your co-author, I think you ought to change your subtitles here. That doesn't seem to me to be rich, so just think about that. On the crowd out issue, actually, there are a couple of crowd out issues that Mark raised. One, which is, I'm going back to an older one first, the crowd out of family care, that when we offer insurance and formal protections, that we crowd out family care. That's been a concern as long it's a concern with the Medicaid program. It's a concern, has always been a concern. And we have a large body of research that shows us that families hang in, and that although there are changes in the tasks they perform, making it much more manageable and probably improved quality of life, that I am not certain is in the literature, but I'd bet on it. We do not lose family care when we provide formal care. Now, that is of lesser concern because I think families too need this insurance because they are killing themselves providing this care. And so I think if we better spread risk, that families will do a lot of things that they are now inhibited from doing, like live their middle years more productively, earning more revenues and doing more for their kids. So I think there are lots of issues there. On the crowd out of insurance, it was really quite a pleasure to listen at the commission to Jeffrey Brown express what he thinks he found in his research, because I think it's not always properly stated. And what he thinks he found is that if you do an analysis of the extra value that people gain over Medicaid from buying private long-term care insurance, so this is really an analytic exercise, you will find that they don't get a lot of value. And it was on that basis that he argued that there's not utility in buying it, and that's how he assesses that there is crowd out. But then he says two things. One is, he said, he does not think that explains the absence of private long-term care insurance, and he actually said it again to a reporter fairly recently in response to Paul Ryan's using it as an example of a misuse of public resources here, that Medicaid, that look at other factors that are affecting buying. And when you look at and it's got to do with the challenges and the actual value of the product, as well as what you said about the buyer side and ignorance about needs. But it's not, in many cases, a very good buy. And so
Okay.
Bruce, okay.
Bruce, yeah.
You got my
made your
point?
point. You made your
You got
point.
my point.
Bruce.
Well, maybe just to reframe this particular discussion a little bit, and maybe from my odd perspective, because I'm the only physician who's up here, and I think, from all my years of clinical practice, and frankly from the extensive polling work that we've done ourselves and other foundations have done, I want to say this with all due respect to the full range of views that are on this panel. I think we're having the wrong discussion. So at the end of the day, and people can pick and choose their data points all they like from both sides of the ledger, and we've heard a little bit of that in this last colloquy. Families don't know who pays for long-term care. Let's just get really simple for a second. So with all due respect, I mean, I really respect the research. This is not a comment about the quality of the technical research. People do not know. I mean, I just start with all of you as N of ones and your families that you care for. Nobody knows who pays for long-term care. Depending on the survey you look at, 40 to 70% of people think Medicare pay for it. I mean, it's all over the board. So with all due respect, there is an enormous body of data, mostly in the polling and kind of social research side of the equation, that says that people just don't know. And so this notion that Medicaid, there's this great Medicaid carve-out, I just don't think that operates in the real world. Even if you can do technical studies that can show in some circumstances there may be an effect. There may be. I mean, this is not causation, folks. This is, at best, an association. And these associations are being defined with very strict terms. So if you're only looking at single older people, what does that mean for people who are families? Lots of older people still have a spouse. So when you set very narrow technical parameters for the purposes of research, you've got to understand the limitations of those technical parameters. So I'm not saying that there is no Medicaid carve-out, because I don't crowd out. I don't think I know enough to say that. But I'm just saying that I don't think the context is right. I mean, if it exists, to my mind, it's a small issue and we don't really understand well where it exists. All we've been able to identify is that it may be an issue in some circumstances. For me, what this really comes down to is that there's a lack of understanding that people need to plan for this need. And, Judy mentioned the sort of two sides of the coin in her comments. And so she went through the detailed table, which I think is a very important one, the 30% who don't need and the 20% who need 5 or more years. But the simplified version is that 70% of people will need something, and they need a plan for that. And so I think it's filling that. So there's a knowledge void that needs to be filled. And then there needs to be a set of tools that help people get there. And in that set of tools, that may mean that we fundamentally need to rethink the role of Medicaid. But first, we need a set of tools that are there that provide some context for rethinking about what the role of Medicaid is. Right now, people have very poor choices. Long-term care insurance is not affordable for most people. Having rates go up 80-odd%, even if there are good macroeconomic reasons, is not reasonable in the life of an older person. I get the business imperative why a firm might want to do that, and I respect the private sector, and you got to be right side up. You got to care for the folks who you have a responsibility for, but that doesn't work in the lives of real people. And in fact, it brings you to the death spiral that people always worry about in insurance, because for a lot of people, they can't afford that. They'll walk away, and the folks who really need it will hang on, which makes actually your actuarial profile look worse. So I think for us to move forward here, we're going to need to reframe this discussion in a way that really gets at how do you solve the problem, and then what's the rightful place for Medicaid, as part of that solve. And we need to get real about changes on the edges of the envelope to make that work properly. And, that may mean that Medicaid plays a different role than it plays today. And that's a hard thing for people to hear, but...
Thanks. We're going to go to the audience now, but I thought since we have two other important participants in the commission, if they wanted to make a comment, now's a good time. Larry? No. Compliments are not accepted. We only want substantive comments now. Grace Marie, I think, wanted to make a comment.
I agree. I think it was a very good discussion, and I really want to thank both Bruce and Mark especially for their hard work in getting a report done in 100 days. But I think this conversation really shows why it was so difficult to get to the point of one single financing solution for long-term care insurance. I think that there was in the report, there were a multiplicity of solutions, and I think that really should be a starting point for policymakers as they begin to look at who needs help and what kind of solutions, so that some of them may be private sector solutions that Mark was talking about, and others may require public sector support. But within 100 days, I think we did a pretty good job of at least showing, and this conversation has as well, the difficulties of getting to a single solution.
Okay, thank you. So now, questions? Can you be second? John?
Thank you, Joe. My compliments.
Please identify yourself. Thank you.
John Rother. I'm now with the National Coalition on Healthcare, but my remarks come out of my 27 years at AARP, and I have to say, first of all, that I'm disheartened that we haven't moved the discussion much further than it was 25 years ago. So let me say three things just very quickly. First, in response to Bruce, all of the focus group work and polling that we've done has convinced me that this is not a matter of education. It's a matter of a very powerful psychological dynamic called denial. And you can put facts in front of people, but unless you're going to give them an answer to the problem, just telling them there's a problem is just going to meet with resistance.
Right.
Secondly, I really like the idea of linking long-term care to an annuity. We have a great annuity program that works very well called Social Security, and we could easily link long-term care to Social Security and have all the advantages that Mark mentioned. Thirdly, though, it seems to me that we ought to try to disaggregate what we're talking about. And from my point of view, there are four ways to look at this that might make it easier to go forward. One way is healthcare. When we have capitated healthcare plans, we have more flexibility about what's covered, and we have the ability of plans to intervene with social services in a way that could save healthcare dollars. And I think that gives us some flexibility. Secondly, we have disability. And disability insurance, I think, is a very relevant mechanism for this population, particularly younger people, but also older people. And I think we ought to think about how to expand the current disability program. Fourth, we have housing. Housing is not something I think that should be covered necessarily by insurance, but we ought to think about how to give people tools to move to more appropriate housing when they need it. And then finally, and probably most importantly, there's the role of family caregivers. And unless we do something to shore up the family caregiving, all the rest is going to be washed away in a tide of rising needs. So I would put the emphasis very initially on helping family caregivers. It is going to cost a little money, but it's going to save in the long run. And more importantly, if we can just get away from money, we should be talking about quality of life and dignity at the end of life and what helps families to do what they really want to do for their loved ones.
Thank you, John. Comments?
Actually, I will take the opportunity to comment about two of your points about disability and about housing. I feel strongly that this issue, although it's often combined to talk about the elderly and about the working age population, people who are disabled in that segment, and the programs, Medicaid does cover both, and that's a reason for putting them together. And as I understand, there's some interest group issues and politics that are involved here also. I firmly believe, though, as an analytical, as a policy matter, that they're really two separate issues, because the elderly, when we talk about the elderly, certainly for a significant segment, it's something that it's an issue of planning. But for the working age population, the disability, disabled in that segment of the population that do need long-term care, it's not a matter of planning. I fully acknowledge that. But I don't think that the Social Security Disability Insurance Program is the one to handle that. It's going to go broke in 2016. So I don't think, and the way it's the adjudication process for that program is a gigantic mess. I was on the advisory board, Social Security Advisory Board. It's a broken system. In terms of housing, I definitely think that is a source of funding, and there are people talk about reverse mortgages. I think there are some innovative ideas out there that some people are trying to bring to the market that could use housing as a source of financing for long-term care, and I think they should be encouraged.
My name is Barbara Dello, and for 29 years I was a long-term care nurse, and Dad now lives with us. It's wonderful, exhausting, confining, and getting help is expensive and undependable. And I want to cry when I hear you talk about risk and the enormity of the problem. We need your help. My question is, why are millions of dollars being cut from long-term care when so many more government dollars are being shifted to well patients and enormous bureaucratic growth? Does this reflect that our own society, government, insurance industries has lost its commitment to the frail and elderly in our society?
I can see nobody else wants to take that. No. One might feel, I certainly feel, that there's misplaced emphasis in terms of health care, long-term care, and a lot of other things. Education, roads. We don't want bridges to fall out from underneath us. There's a lot of misallocation in a big government system. I think that's partly what you're seeing. But the idea that we've somehow decided that we're just not going to care about older people is politically absolutely wrong. And in terms of long-term care, that's been the difficult topic, after all, because for politicians, there's no immediate gratification. And ultimately, that's where we are in this country.
Just briefly, I want to thank you for speaking, and I think that what you're talking about is the kind of personal experience that we need public and political action to address. So I'm hoping that this is the beginning of trying to address it.
I just wanted to follow up on what John talked about and what Mark talked about with disability and disability insurance and the population that's
By the way, this is Larry
still,
Atkins.
quote unquote working age. I'll say thank you, Joe. Thank you. But I wanted to raise a point that came up in the commission. I think it's a very important point, which is that for the population that's still of working age, disability is essentially a retirement program. It's a program that takes people out of the workforce, and it is a program where eligibility is based upon non-work, earning less than a particular level. So where we have functional needs that where people can still work with a degree of assistance, we don't have a way to provide help for those people because health insurance doesn't cover those costs, and in order to get anything from the Medicaid program, you have to basically stop working. So I think the problem is linking functional limitations to disability and non-work create kind of a dysfunctional relationship, which is not helping people in that age group. And from the standpoint of trying to keep people in the workforce, it's really counterproductive if we can help to keep people in the workforce. So I think there's a need to disconnect a little bit. We talk a lot about seniors, where we have a lot of time to prepare for old age, and people are expected to save or insure or whatever. But almost half of the population is not in that category. They're people whose dependencies come up quickly. They have very little time to accumulate anything. Families run very quickly through all of their own resources, and they're essentially pulled out of the workforce, whether they are capable or not, and forced to get into a public assistance program. So I think there just needs to be a much more creative solution, and I think the commission recommended we should start thinking about maybe delinking the functional assistance from the concept of disability.
Joe, can I just say something? I just want to point everybody to another resource. A colleague of mine just released a report yesterday. He's at RAND. His name is Rajiv Ramchand, and he just released a report on military caregivers. There's actually a lot of new and very rich data in this report about family caregiving as a whole in the U.S., but also this is becoming a much more important issue with respect to families of people who've served in the military since 9/11, and really recommend the report and the resource for all of you.
Anybody else? Carl first.
Hi, Carl Polzer, independent consultant, and it's a great day. I got to walk here on a beautiful day, and I found out I was rich when I got here. So thank you very much. My wife has a federal. My wife has a federal job, and I have Social Security. So, like, as a rich guy planning ahead for retirement, and I'm getting there, I see two big. The main point of what I'm going to say is this issue overlaps with a lot of discussions that are now going on in retirement policy, and that's not a static issue. We're having a tectonic shift there, going from defined benefit to defined contribution. So the level of pooling in our retirement system is decreasing on the private side. So when we think about, well, like rich guys like me, when I think about what I might need, two big risks. One is I might need all this long-term care stuff. And the other one is I might live, there's no way under the 401k system you can tell how long you're going to live, especially for a woman. A male, maybe I won't make it. My wife is probably going to live a long time. So how do you plan for that? So when we think about these problems, I think longevity risk should be on the table along with the risk of falling apart expensively. And anyhow, that's what I just think that's something to say.
Even though it wasn't a question, I'll sort of chime in just to sort of agree with you that, and part of that was my motivation in terms of designing this life care annuity, because it does address both issues, both the issue of needing long-term care as well as the issue of living a long time and needing the assets to support yourself in retirement. So it was motivated by both issues. And I think we're going to need, and there's some people in the insurance industry here, I think we need to challenge them to come up with ideas and products that will address these issues. Absolutely, 100% agreement.
And then rich guys like you will be able to buy it.
Hi, I'm John Green with the National Association of Health Underwriters, and my guys are agents and brokers, and I believe in the private market. So, hearkening back to the old days and the old debates and arguments that we've had for the last 15 years, I'll resurrect the 125 proposition that if we could sell it in a group market at a group rate with preferred underwriting, it's portable, you can take it with you. I think it would really give a shot in the arm to the private market and get to people who are still attached to the workforce before they retire. It's the same premium when they leave as it is when they're working. And why not, look, Medicaid is here to stay. It's a limited budget. Why not keep that budget as robust for those that truly need it in the safety net and allow people who could take care of themselves do so? If you look at the partnership statistics, you ask the question about, first of all, people hang on to these policies. They don't get rid of them even when the prices go up dramatically, which is unfortunate. But how many actually go into Medicaid? Very few, because this is pays first, and then Medicaid's the backstop, and very few people live beyond that. And some do, but the statistics show that it's really, really, really small. And it's just, I want Medicaid to be there as a safety net for people who really need it, but I don't know why we can't do this 125 thing. It scored at 10 billion over 10, and I remember hearing, woohoo, where are we going to get the money for that? We just spent over $1 trillion on the ACA to move the needle 5%. We now talk in terms of trillions. I don't think 10 billion over 10 is that much. We got to do something to just see if we can, either through a demonstration with Medicaid and maybe the 125, but let's test something and see if something actually works instead of it being a zero-sum game. And well, we can't do this. We have to have it all social insurance, and the other side saying, well, we can't deal with, social insurance. Maybe there could be a couple of experiments that we could try.
Let me just raise a question, John. So the federal government offers long-term care insurance to its employees. And I think the first year, for a period of a month or two, it may have even been offered without underwriting it, without having to go through a physical or, basically reveal your true risks to the extent that you knew them. And yet, I think the take-up rate has been, even in that period, was quite low, and it remains quite low. Okay, I'll repeat that then. John points out that this was a program that wasn't pre-tax, and so you have to pay a dollar for a dollar, and that's an issue for people. I think that's certainly part of it, but I think there must be some educational aspect to this that was missing. It probably has, denial probably has a lot to do with it. Okay, briefly.
I'm Dr. Caroline Poplin. I'm a physician. I was going to make John Rother's point that maybe we could reduce the cost, and that would help with raising the money. But I looked at long-term care. I looked at it when I was in the federal government when it was offered, and the problem was it was only for nursing homes, and I wasn't planning to spend a long time in a nursing home, and I know how to avoid that. Then when I left the federal government, I looked at it again. I was 62. They were saying it was $3,000 a year, which was reasonable, except that it was a problem somebody raised here. It wasn't for something this year. It was something for maybe 20 or 25 years out. And if I stopped paying for a few months, I lost it all. I had to start all over again. I wasn't accumulating anything. And as a business model, this just didn't seem to make sense to me. So I declined.
The premiums go up too.
All it says is this is a complicated, expensive proposition, sir. I'll get to you.
My name's Morris Klein. I'm a private attorney. Just to respond to the last couple comments, in my observation, people, as they go through life, they have to pay a mortgage, they have to set aside money for their children for college. By the time they've paid for all those things, and now they're looking at long-term care and look into a long-term care insurance policy, they might be in their 60s. Many of them can't get it because of the medical underwriting. And where are they then? They're sort of stuck. So to me anyway, this crowd out that's sort of talked about is sort of maybe looking from the wrong direction, is that it's hard to get long-term care insurance when you're able to get it because of financial reasons, and then when you can't afford it, you can't get it because you're considered to be too sick. And I've seen that many times as sort of a paradox about the problem of why long-term care insurance isn't that successful.
Yeah, that's important. There are people back there against the window.
Hi, thanks. My name is Hannah Weinberger-Divac, and I'm with the National Senior Citizens Law Center. And I wanted to build on some of the comments that have already been made about nursing facilities versus home and community-based care. And it seems like some of your proposals, specifically Mr. Rorschachski's proposal, looks to me like it is a better fit, particularly the Medicaid eligibility tightening for people who are going to nursing homes and not for people who are staying in their own homes. And then to the panel, to what extent can long-term care financing be used to move the ball forward to help people stay in their homes as they age, rather than continuing with this Medicaid presumption that we have that always covers people who go into nursing facilities, but state by state it depends whether you're going to get really good comprehensive home and community-based care.
So,
Do you want to go in?
yeah, so that's precisely what, and I'll let Judy respond on with respect to the proposal, but that's precisely what, presumably if we were able to create a long-term care insurance program, whether it's private or public, but a mechanism through which most Americans could be insured against the risk of the expense of long-term care, that they would be able to use those benefits if they were to need them in any setting in which they chose or were able to get the services, and that there would be flexibility around that. And certainly, the Class Act was designed that way with that very goal in mind. And that's why the benefits were a cash benefit. So I think that would certainly be a goal of any insurance mechanism that we would be, debating at this point.
And I would just say, I think that, absolutely, and that the key, though, is that we're only going to get that if we improve the financing. And the goal of having something that is more appealing than exhausting all your resources until you're impoverished, and the goal of having something that people can care about and feel that will be there for them in order to generate the willingness to invest through tax resources, premiums, whatever we decided, I think is what we need in order to have a decent system.
I'll just comment that in the commission report, we all signed on to, and I think even the people who didn't sign onto the report would agreed with this point of the need for rebalancing. But given the fiscal realities, again, I think we need to look for private sources of funding. And it's my belief, and it's not even a belief. I think it's been realized that the private sector does respond to what people want. So, in point of fact, long-term care. I mean, just sort of echoing, sort of responding to one of the other comments. It initially did just cover a nursing home, and then it wasn't popular. And they've expanded it, and I think we could encourage that even further. The life care annuity is a cash benefit, which I agree. I like that approach also.
Vic Miller, private fiscal economist. I'm one of those rich guys who get to be 70 this year and have deferred my Social Security till this year, in June. It seems to me that I don't know if anyone's done a poll of whether people would be willing to take a piece, have the federal government save some of their Social Security and save some of their Medicare, put it aside, and when they get to be a certain age, 75, that will be their long-term care insurance, funded out of the current programs. Is that possible? Has anyone asked that question?
I am familiar with a professor up in the Boston area, I think, who Bing Chen, right, who did propose that idea. I won't comment further.
In that sense, I guess I would call to everybody's attention a study we did that I think has not yet been reanalyzed, but will soon, estimating of a whole variety of proposals. So if you go to ltc.georgetown.edu, Mark's proposal was done for that project at Georgetown. Ann did one, and so did Bing Chen.
Okay, well, if you're only living on Social Security, that probably doesn't sound like a great idea. If, on the other hand, as increasingly people will be living on partly Social Security, but partly the proceeds from the IRAs and other kinds of contributory retirement programs, it might be attractive to some extent. But, of course, once again, we go back to the problem we started at the beginning. This is putting money aside for something you don't want to buy. And I'm not talking about insurance now. You don't really want to get old. I would say that is a view of nearly everybody in this room. And with that, I want to thank everyone and thank the panel for our terrific session.